Hi, this is Brian Kim. I want to share with you case number 194 in the Best Way to Do Cataract Surgery series. This is a patient with a Catarock, and you're going to see terminal chop, cross chop, and then hooking the peripheral lens with the chopper, pulling it centrally toward the fingertip, crushing the lens in the typical cross chop manner, and then crushing the lens with opposing forces over and over again until the pieces are small enough. By doing it this way, you're able to disassemble a very dense lens and cause minimal zonular stress. So this is the lens. You can see it's quite a bit of a dense lens. I'm using the cotton tip to steady the eye, and then this is a corneal marker which will help me to center and size the rhexis. You're going to see here the patient has a little bit of a Bell's reflex. I'm using the cotton tip to control the eye, making my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see on the left side incision, the patient's having a harder time looking down. Again, this is the right eye, and so I'm using the cotton tip to control the eye, pushing the eye down, make my incision. Using the cotton tip to steady the eye, this is intracameral lidocaine and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then when I'm ready to enter, I turn the eye towards me with a cannula, and then I enter. You can see this patient has quite a bit of a Bell's reflex, and I'm holding the eye with the cannula straight. So again, with the right eye, you can place your cannula through your incision, and this will help keep the eye from rolling up. And so I'm just resting that cannula on the patient's orbital rim. And this is the sharp tip Hydrodissection forceps. I puncture the center, pull down towards me, grabbing the right side of the tear, going around circumferentially. I have exquisite control, and I'm able to prevent the Bell's reflex with the cannula. And if the patient's chamber starts to collapse, I can use that cannula to push some more viscoelastic to stabilize the rhexis. Very versatile technique. Once I'm done with that step, I go ahead and take the cannula out, and this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, turn the cannula back up, decompress on the left side, sweeping and pushing BSS along the anterior capsule on the left side, and then sweeping on the right side, and the lens begins to spin. And so again, this is a dense lens, and rather than trying to chop it fully and risk getting a posterior plate, I've decided not to do that anymore with these super dense lenses, and I like to debulk the center. And to me, the best way to efficiently debulk the center and then achieve full thickness chop is really the terminal chop technique. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. And then I'm turning bevel up and I begin to sculpt. Go ahead and sculpt the groove. I'm in the dense setting mode. Using longitudinal ultrasonic energy, I'm able to efficiently cut through the lens with sculpt mode, making sure I cut efficiently, and I'm very ginger about pushing down on the zonules. I don't really want to crank down and push too hard, and so I'm very careful and gingerly pushing down as I'm sculpting. And you want to go about the diameter of the rhexis, but you don't have to go too crazy. You don't even have to go full length. You can go a little bit shorter diameter, but the point is you want to debulk the center. You want to get a nice central debulking of the lens, and this is a terminal chopper. Place the chopper out across the equator on the terminal side, pull it centrally toward the fingertip, fracturing the lens from the terminal side. I'm able to crack and propagate the tear all the way through and through. You can see I'm able to disassemble and create two heminuclei. I place the chopper around the right heminucleus, pulling it centrally toward the phaco tip, fracturing the lens against the phaco tip like it's a chopping block, and that is the cross chop. Placing the chopper around the first quadrant, hooking the peripheral lens, pulling it centrally toward the phaco tip, fracturing the lens completely in half against the phaco tip, and that is another cross chop maneuver. Lifting that first fragment up with some vacuum, crushing the lens between the instruments, and then emulsifying the lens piece. Placing the chopper around that other fragment, crushing it against the phaco tip, using some vacuum to grab the piece, crushing the lens between the instruments, and then emulsifying the lens piece. Placing the chopper around the second quadrant, hooking the peripheral lens, crushing it against the phaco tip, dividing that lens piece in half, separating the lens piece, getting around that fragment with the chopper, and crushing the lens against the phaco tip in a very similar fashion. This again, multiple cross chop maneuvers, crushing the lens into smaller and smaller pieces. And you saw there, I just turned the chopper sideways, got underneath the lens, and then fractured the lens with opposing forces with mechanical fracturing techniques. So you can see here with those maneuvers, I'm able to turn the chopper sideways. It's not pointed down, it's actually pointed sideways. I'm able to get under the lens and then crush the lens with opposing forces, and then emulsifying the lens pieces. So placing the chopper around that lens, hooking the peripheral lens and popping it up with the chopper, and then emulsifying the lens piece. Turning that second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip, fracturing the lens against the phaco tip like it is a chopping block. Now you have a third and fourth quadrant, separating the lens piece again. And by doing it this way, you help reduce the risk for any posterior adhesions. Placing the chopper around the third quadrant, hooking the peripheral lens, crushing it against the phaco tip by pulling it towards the phaco tip centrally, and then crushing the lens into smaller and smaller pieces, and then emulsifying the lens piece. Very controlled and systematic way to disassemble the lens, using some vacuum to grab that fragment up, crushing it between the instruments, and then emulsifying the lens pieces. You can see that most of the CDE was actually created during the initial sculpting of the groove. Rotating the fourth quadrant in front of me, hooking the peripheral lens, didn't quite get around it, and then positioning the phaco tip deep, and that allows that opposing force to crack and separate the lens into two pieces, getting the chopper around that fragment, hooking the peripheral lens, pulling it centrally toward the phaco tip, and then crushing it. Using some vacuum to grab that piece, and then crushing the lens piece once again. So again, using sparing amounts of vacuum to position the piece on the tip, and then crushing it with the chopper is another thing you can do. Again, it's a very controlled way. You're not going after pieces with high vacuum. It's just a little bit of vacuum to just grab the piece, just like that. So grabbing it, positioning it, hooking the peripheral lens, crushing it between the instruments, and then emulsifying the lens piece. This is the final endonuclear piece here. Tried to grab it with some vacuum. Didn't work. Repositioned it, grabbed it again, lifted it up, crushing it between the instruments, and then emulsifying the lens piece. You can see the chopper is deep, but you see I also have a nice, robust epinuclear shell that's protecting me from the posterior capsule. And then removing each of those thick epinuclear pieces, keeping the chopper deep in the bag to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, go in with the ironing handpiece, starting sub-incisionally peeling off the cortical material from anterior to posterior. You can see it's a relatively clean bag, which is pretty typical with these super dense cataracts. Again, the epinucleus tends to be real thick and stiff. Polishing underneath the rhexis edge. I spent a lot of time polishing under the rhexis edge and also polishing into the capsule fornix just to look for any hidden lens material. Pulsing into the subincisional capsule fornix, which is rather clean. There's some fine fragments that came out, but no huge sheets of cortical material. And this is cohesive viscoelastic to fill the bag, disengage the irrigation, and then fill the bag. You don't want irrigation on when you're pushing the viscoelastic in, otherwise it just comes right out. Using the sweep to polish underneath the rhexis edge to remove the lens epithelial cells. And in this case, I like to use 2 instruments to hold the eye steady. Again, you saw the cannula was holding the eye, again, because this patient has a Bell's reflex. Nice to have that cannula in there while I'm trying to sweep. It gives me extra control. When sweeping on the right side, you can see the sweep is also functioning to prevent the Bell's reflex. So in this case, I don't really need to have 2 instruments. Go ahead and widen the incision for the 3-piece lens. Go in, bevel down, turn the bevel to the left. Before I advance the lens, I push some more viscoelastic to fill the capsular bag. Deliver the leading haptic into the bag. Whenever you're putting a 3-piece lens in the bag, you want to make sure the capsular bag is completely inflated. You don't want any folds or wrinkles in the bag, which could potentially lead to posterior capsule rupture if you're not careful when you deliver the lens. Go ahead and deliver the optic and then use the multimeter to dial the trailing haptic into the bag. Go in with irrigation off, activate irrigation, removing the viscoelastic from underneath the lens. Polishing underneath the rhexis edge. Removing all the viscoelastic within the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a Catarock. You saw terminal chop to debulk the center, and then you fracture from the terminal side contra-incisionally. By fracturing the lens from the terminal side, you are actually fracturing the posterior lens material as well. And because of that, you're able to crack from the terminal side, which propagates through and through, all the way from the distal side to the proximal side. Again, I use the example of Pac-Man. You don't want to be trying to crack Pac-Man at his teeth. That is the most inefficient way to try to crack the jaw. If you're trying to crack Pac-Man completely, you have to crack it from the jaw, not at the teeth. Get to the source of the adhesion. And so when you fracture the posterior lens from the terminal side, from the equatorial side, you're able to propagate that crack all the way through and through into the proximal lens, and you get a full thickness cracking of the lens and therefore bypassing and avoiding the posterior plate phenomenon. And then you saw multiple uses of cross chop where you place the chopper around the lens contra-incisionally, pulling the chopper towards the phaco tip, crushing the lens in the process. Because the phaco tip acts like a chopping block, you're able to efficiently crush the lens into smaller and smaller pieces, bringing the lens pieces into the central safe zone rather than pushing into the lens with high vacuum or ultrasonic energy. You're hooking the peripheral lens and bringing it up and then crushing it against the phaco tip. Very efficient way to disassemble the lens using sparing amounts of ultrasonic energy and vacuum. And you can take this Catarock case, which typically you'll end up with a steamy cornea, but not in this case. You'll end up with a clear cornea postoperatively. In this case, this patient is a patient in a facility, and so in those patients, I'm not as confident that they're getting their eye medicines after surgery. This patient also said they're not able to put eye drops in very well, and as a result, we'll go ahead and put some subconj antibiotics and steroids at the end of the case. This patient had a clear cornea post-op day 1 and was very happy with the result. So I hope this was helpful to you, and I thank you for your attention.